Hi everyone, my name is Teresa Casanovas. I am a pathologist and now ELPA Scientific Committee Coordinator. On Rare Liver Diseases Week 2023, we would like to update you about some rare liver diseases, and we would like to talk about children's liver transplant. Today, we have the opportunity and the honor to have Dr. Loreto Hierro, a pediatric hepatologist specializing in children's liver transplants. She works in the Children's Liver Transplant Unit at Hospital La Paz in Madrid. The first pediatric liver transplant performed at the Hospital La Paz was carried out in 1986, and Dr. Loreto Hierro has been working there from the beginning. Hospital La Paz leads the European Transplant Child Reference Network, created to train professionals from 18 hospitals in 11 countries of the European Union. The objective is to share knowledge about diseases associated with transplantation and develop treatment projects that, although they have been already used in adults, need validation in children. Nowadays, pediatric liver transplantation has dramatically changed the prognosis for many infants and children with liver failure and metabolic diseases. The most typical indication for liver transplantation in children is biliary atresia, which accounts for more than 50% of children requiring liver transplantation. The majority of these patients require liver transplantation before the age of 2 years. Based on the European Liver Transplant Registry between 1968 and 2017, and despite increasingly complex and younger recipients, patient survival improved over time, achieving an overall 5-year survival rate of 86% in the current era. Remarkable advances have been made in pediatric liver transplant recipients, surgical and medical management. However, a singular focus on survival provides an incomplete view of the prognosis of children undergoing liver transplant. And transplant care must focus on innovations considering improving the quality of life for children after transplants. I am sure that Dr. Loreto Hierro and her team at Hospital La Paz meet excellent technical requirements in the field of pediatric liver transplant and the more purely humanistic aspects and support for patients and families. Today, Dr. Loreto Hierro's talk focuses on the results on children pediatric liver transplant for biliary atresia in 2023. Thank you, Doctor, for your commitment for patients. Thank you very much.
Good morning. I am Loreto Hierro from Hospital La Paz in Madrid. I am going to show you the results in the disease biliary atresia at the moment. Biliary means related to bile, and bile is a secretion of the liver that is sent to intestine through conduits. In general, they are named biliary tree, and bile in the intestine enhances fat absorption. Atresia means lack of a conduit in the body, so biliary atresia means lack of the conduit. The basic knowledge in this disease is that it is not an hereditary disease. It occurs in 1 in 17,000 newborns. It is of unknown cause, but the inflammation of the biliary ducts seems to be the pathogenia of the disease. Probably it starts near birth, this inflammation, and scarring due to inflammation causes the obstruction of biliary ducts. You can see in the photograph a duct that is having no lumen because of scarring. Also, there is liver damage, and this is due to inflammation, probably of the same nature of inflammation in the biliary ducts, but there is another cause of damage, that is the retention of bile components inside the liver cells. When we see children with biliary atresia, we confirm fibrous occlusion of the bile ducts that can be apart or interesting all biliary tree. That is the most common form. The entire extrahepatic ducts are occluded because of scarring. When a child with biliary atresia is born, the exploration is normal. First days since birth, it appears that the child has jaundice, that means a yellow color of the skin and mucous, and also soon after birth, in the first days, but maybe that parents are not able to detect this is abnormal, there are very pale stools that are white or grey color. It is only after 1 month or 1.5 months that the disease of the liver becomes evident for family, because the child is not only jaundice and has a brownish urine and pale stools, but also a distended abdomen due to hepatomegaly, and begins not growing well. So the average diagnosis is near 60 days of life, and it is better for the deceased to detect it earlier. That's why in some countries all families of newborn babies have a chart of stool colors of newborns, and there are some colors normal and some colors abnormal that indicate that the family must communicate this to the pediatrician. The diagnosis of biliary atresia is made upon some clinical symptoms, the jaundice, the pale stools, very basic liver tests that show that bilirubin is high and gamma GT is high, the ultrasound in which we see that the gallbladder is small, and we perform some studies about bacterial infection, virus infection, level of hormones. We see if there is a malformation in the body, and the level of protein that is a marker of another disease. Sometimes we have time to perform a biopsy that may help in diagnosis, but diagnosis is only confirmed by opening the abdomen and the direct view of bile ducts. The surgeon sees that there is no patent extrahepatic duct. Then the surgeon performs the treatment of the disease, that is a new conduit for bile made of intestine of the child. You can see in this cartoon a segment about 15 centimeters is placed between the entrail in the liver and the other part of the intestine. This operation is named Kasai. And after the operation, the child receives antibiotics, some medications that are enhancers of the liver production of bile, vitamins, and usually breastfeeding is complemented with special formulas because it will take time to restore the capacity of absorption of fat food. After the Kasai, we wait 2 months until we determine the Kasai is successful, and it is indicated by the absence of jaundice in the child. Bilirubin is less than 2 milligrams per deciliter. It occurs in about half of the children that have been operated, and means that the bile flow has been reestablished. This situation allows survival with own liver and good quality of life, but in the first year especially, biliary infections that are named cholangitis may occur and need antibiotics. And along the time, the liver manifests signs of scarring, of fibrosis, and some varices develop in stomach, and the spleen gets larger and thrombocytopenia can occur. Thus, along the time of the life during childhood, most of the children will need a liver transplant to treat problems due to the hard liver. We speak about a failed Kasai when 2 months after the operation the child still has jaundice. It occurs in 50%, and what this means, the surgeon is the same, a skilled surgeon in any country, even doing the operation adequately, the child can have no success because probably the liver damage developed before operation does not allow to produce bile. Then in these children there is a progressive and very rapid liver disease. Nutrition usually needs support by a nasogastric tube, and complications of liver failure begin around 6 months of age. So these children not responding to Kasai will need a liver transplantation soon, usually performed between the age of 6 to 12 months. Liver transplantation is thus the second step of treatment in biliary atresia, and it is performed when the child needs, but preferably avoiding too much advanced liver disease. The diseased liver is substituted by a graft from donor, and there are different modalities. All are working well, and the child can have a whole liver, a partial liver to fit the child, the size of the child. A liver can be splitted to the transplant of 2 patients of different size, and if the child is less than 4 years, they can receive a part of the liver of the parents. The life after liver transplantation is a good life, good quality, allows scholarization, social life, work, having a family, and after transplantation, immunosuppressants are necessary to avoid rejection. This medication, the current time, is very well tolerated and has very little toxicity. The problems that may arise after a liver transplantation are many. In early time, a thrombosis is the most feared complication. It occurs only in 2%, but needs usually a new transplantation. In the medium term, about 20% of children have a stenosis of the bile duct and needs a radiological repair. At any time, doctors perform surveillance of EBV infection. This is the virus that causes infectious mononucleosis in normal people, and when this infection occurs after liver transplantation, usually it is needed a modulation of the medication, lowering the immunosuppressant to prevent that the infection lead to a lymphoma. And there is another complication, that is not taking well the medications. It can occur rejection at any time and the liver can be lost. So this is prevented by education of the child and of the family, and is of utmost importance with medication. You can see here that the results of liver transplantation in children with biliary atresia are very good. The disease is only in the liver, and if the new liver works well, the survival is usual. This is the experience at my hospital. In the last 20 years, 189 children underwent liver transplantation for biliary atresia, usually very early in life. You can see that after 18 years, 92% are alive and 80% have normal liver tests. The transplantation is a kind of cure of the disease, and some children unfortunately not reach the possibility of liver transplantation because of a very rapid evolution of disease, but this is only at 2% in Spain. So my message is for you is that the research is ongoing to know the cause of biliary atresia, and thus to look for appropriate treatment and prevention. And research is also ongoing to find better medical treatment preventing fibrosis of the liver. But with the current treatment with Kasai and liver transplantation, 90% of children with biliary atresia survive in good condition in the long term. It has been a pleasure to explain it for you. Thank you.